in order to provide contrast, we have Ilan next, who's going to talk about when and how to do double balloon therapy. Ilan is Professor of Obstetrics and Gynaecology at NYU School of Medicine and also scientific editor of the Journal of Ultrasound in Medicine. He is well known to most of you and doesn't really need an announcement, but he's a well-respected expert in the field of cesarean scar pregnancy and morbidly therein presented. Thank you, Ilan, so much for making the time to come and talk.
I will talk only about one single aspect of treatment, and again, I'm feeling frustration because I couldn't say anything about the other management kinds of management. So let me give some credits. I'm really standing on the shoulders of my peers who really taught me all what I know about cesarean scar pregnancies. They started early in the late 1990s and the early 2000s. And standing out of these were Ivan Vial in Switzerland, Davor Jurkovic in the UK, whom I know from his Croatian connection, probably many more years than I care to because it was old times. And Chrissy Comstock in the USA, whom I learned from a lot. Notwithstanding other scores of other clinicians, the names would take too long to mention here, they care to publish their observations leading to at least 2,647 posted articles of today. And if I also put in cesarean scar ectopics, there are another 700. I will be mentioning only the management of scar pregnancy, but more specifically one of them that I frequently, but very clearly not exclusively use. So here are the management, and they can be classified as one of the following: major surgery, and we have heard about some of them, and you can read them right here. Different kinds of surgeries, dilatations, aspirations, laparoscopy, minimally invasive treatment that go without general anesthesia, local injection, then systemic, single, multi-dose, IM, or even intravenous methotrexate, uterine artery embolization, done predominantly as first treatment or combined with others, and then combination of all the above treatments. Then there are the local pressure by inflatable balloons, single Foley, double cervical rifling. My favorite to go to like a general review of the treatments are these by Maleux-Lacroix. She really showed us all the successes and all the perils of it. Our Foley balloon catheter was published after this article, therefore are not included here. So let's all ask, are there guidelines? And it's obvious that none of the countries, including the United States, have a set of guidelines at hand when a patient with an earlier ACRITA or a cesarean scar pregnancy presents. That's why we need an international registry. So let me talk about treatments that are based upon pressure effects. And again, I'm talking about the single and the double balloons. The single balloons were published by us in 2015. And basically it was like place a single balloon as a single treatment or inject a local and place a balloon afterwards. And basically it is based upon this pressure that is put on the scar pregnancy or a cervical pregnancy for that matter. It's several millimeters more south of this one. And then look at the picture and evaluate its efficiency. The story of how this came about is that we published 18 cases, and they were done prophylactically as an adjuvant to the treatment. And we thought that controlling balloon inflation by transvaginal and or transabdominal guidance is easy to perform. It can alleviate severe bleeding, render other more involved risky surgical interventions redundant or or at least add to them. We suggested making the Foley catheter readily available when local, minimally invasive or other treatments are undertaken. However, the balloon slid out spontaneously after 2 days in 2 patients and in that series. And after 5 days in another patient, that was a patient who was treated across a holiday and I had no access to the patient. It was probably caused by uterine or cervical contractions. The uterus doesn't really like too many stuff. That's our luck, because at least spontaneous abortions are expelled also. The idea of using the double balloon, inflating the upper balloon within the cavity to serve as a retaining, or as I say, an anchor balloon during inflation, basically appears logical to us and was tested. So here is the article, and again, so it's simultaneous termination and bleeding prevention, simplifies treatment, minimizes patient discomfort, and we adapt the catheter familiar to the OB in the labor and delivery to treat cervical pregnancy and scar pregnancy. But this is here where I made a misassumption. I realized that not too many places and the places that deliver patients use the cervical ripening balloon. I will talk about that later a little bit. It is high success rate and low complication rate, and the rare complication is really an AVM, extreme myometrial vascularity. Davor talked about it beautifully. That is usually treated by UAE. And Davor, I will try your ligation of that artery that feeds that area. So basically, here I summarize, first of all, the single balloon that you see there inflated and putting pressure, and then the anchor balloon inflation and the inflation of the treatment balloon in our cases. Both have high success, low bleeding, low hysterectomy. And that's the general picture of it. I don't want to come back to. So let's see how it's done live. Here is the tray that I use. And I leave it on to let you see, but you can later access it. I use a curved tenaculum. That's one of my main instruments. I also use a single hinged speculum because I can extract the speculum without manipulating the catheter through its opening. Then I use Hagars in not too many situations. I will talk about that also, and the needle for paracervical block, and of course lidocaine. So here is basically what I do. I do pain management 2 hours before and then every 6 hours, reducing pain due to balloon distension. Now, this is extremely important. When you have a patient with a prior vaginal delivery or DNC, that makes the catheter insertion easier. Without the above, some cervical dilatation may be needed using the paracervical block to accommodate the diameter of the catheter. And to reduce this diameter, I usually use small syringes to aspirate air, collapsing the balloons through the red and the green ports. And after I did that, here is what they look. So they are a little bit less voluminous, and I can push them in easily. So what do? I hold the anterior cervical lip with the curved tenaculum to enable to push the catheter in the cavity. These are my primitive ways to show it. I position the catheter into the cervical external os and then push the catheter into the uterine cavity using a ring forceps guided by a transabdominal ultrasound. Here is where I use transabdominal ultrasound. So this is what's happening. You see the scar pregnancy, the vascularity, the catheter in the cavity, the anchor balloon, compressed gestational sac between the both inflated balloons, and then deflate the lower balloon. I talk about this later. And if you at times want to use it in a lower scar pregnancy or even a cervical pregnancy, I inflate one of the balloons opposite the scar pregnancy and the second one in the vagina. Now watch it live, and this I got from Dr. Marcos Cordova from Michigan, who was one of our MFM fellows. So here it goes. This is the introduction of the catheter under transabdominal guidance. Then I inflate the upper anchor balloon also under transabdominal guidance. Make sure that the bladder is sufficiently full in order to fully see, beautifully see this process. Then I take out the speculum, and on the transvaginal ultrasound, I inflate the lower balloon and assess the size of the upper and lower balloon to see whether I need to top up either of them. Then later on, and I will talk about that later, we deflate the balloon and remove the catheter. So we adjust also the size of the balloons. The lower one, as you see here, watch live how it compresses the pregnancy. This pregnancy, by the way, was pretty dislodged upwards. And then I topped up the upper one in order to really achieve the complete collapse of it. Serum HCG is expected to recede in 2-3 weeks. That's nothing new. We use it in the cervical pregnancy, and you can see here all the stages that I showed you previously with the scar pregnancy. There is nothing new about it. I use also sometimes a 3D to see whether I really place the balloon in the regular place, but that's not really that much necessary. So what are the lessons that we learned under this? After publishing the first article, we received emails, telephone calls, text messages regarding the technique and patient follow-up. Then we published a follow-up article with tips to improve the technique. This is the article, and it was published, I think, a year later or so. So here are the ones that I already showed you, and I mentioned these previously. But here are some other tips that are in this article. Catheter dwelling time. Everybody asks you, how long do you keep it in place? So here is a little story. I thought that I would want to keep the catheter in less and less and less and less. And again, the 3 days is usually over the weekend. I do put in the catheter Friday and then go back and remove it Monday. But I thought that it may be important to do it earlier and earlier. And I think that the ones that I really removed almost the same day, put the back catheter in and then see no heartbeats and take it out in the evening, I think that these were the ones that developed some more vascularity. So I want to really compress the area of the blood supply, and now I leave it in for 3 days. I administer oral antibiotics. I call the patient every day. Here in the States, I do it. You know, lawsuits here, lawsuits there. That's a very good practice. If it was a referral, call the MD with a report. Be nice to him to get more patients. Catheter removal, see this slide. If there are no heartbeats or no recent bleeding, deflate the lower balloon, wait about an hour, then go back after an hour, deflate the upper balloon, wait another 1 hour. Now, if no bleeding is seen, slowly, gently pull out the catheter. Seat the patient in the waiting room until you write the report. If it is not bleeding, then give instructions to her. You rescan in several days and check the HCG. Now comes something pretty important. Please pay attention. Give the patient a discharge report describing the procedure, because if she has to go for some pain, bleeding to a different emergency department, they probably never heard of this entity and this treatment. I advise against surgical removal of the tissue remnants at this point. It may cause severe bleeding, opening up, definitely not a sharp curating. Davor mentioned that very nicely. Wait for serum HCG and vascularity to reach their minimum. And again, consider in this point expectant management. Lastly, the catheter comes in two versions. We suggest the one with the stylet because it provides sturdiness after shaping it to match the curving cervical canal, contributing to an easier insertion. And then be patient, spotting, bleeding. It lasts for 2-3 weeks. Hold the patient's hand on this. And that is due to retained products of the scar pregnancy. So further experience. There are no articles in the literature that attest to quite a lot of cases. I don't exactly know what's happening, maybe 60. Unpublished, maybe another 20, 30. Don't hold me for this slide. Now, I'm looking what my friends do. Palermo, Cali in Italy, 6 to 7 weeks, double cervical ripening catheter. Later on, he does intergestational injection and the balloon. After 11 weeks, he also use embolization and so forth. My friend Francesco D'Antonio in Italy, before 80 weeks, double balloons. After eight weeks, massive vascularization. Again, as Davor correctly pointed out, then he uses methotrexate and uterine Albany embolization. So what are the usual reasons not to use the double balloon? Rightfully or not, every clinician uses the treatment he and she is accustomed or feels comfortable with. Old habits die hard. Not too many people want to change their practice. So look at the excuses and see my answers, because I have an answer for almost everything. Not familiar with the technique. My suggestion, read about it. It's the first step. If your OB uses it in the labor and delivery, watch it being inserted. Or call Timor, here is my number, usually during my daytime. I never heard about it. My suggestion, try the website. Here is an article for it, and read our article that was pretty clear, and also the follow-up article. Or call Timor, 917-520-17177, any New York daytime. I don't work in the labor and delivery. I'm not exposed to its use. We do not ripen the cervix. My suggestion is there is a review that you could read, and here is the review that you can really go to and see how the double balloon is used for cervical ripening. Again, you can call me anytime. We do not perform this in the ultrasound units. I'm worried to use it as an outpatient. Well, my suggestion here is do it in the OR, paracervical block, experience how simple it is. In the ultrasound suite, the sonographer can help operating the machine. We do it only in the ultrasound suite. If you have a resident or a medical student, use their help. If you have a daycare facility, use it to watch or hospitalized over one night, and then maybe later you can use it as a one-day procedure. Or again, call me, but during the daytime, please. I will wait until the different societies will be endorsing this procedure. I have a warning for you in this case. Do not wait for this to happen anytime soon. If you wait, you will grow a long and funny beard by that time. And you ladies, you will grow a very, very long hair. And then there is one, I don't like Timor. He's obnoxious talking about balloons. He insists that scar pregnancy is not an ectopic. My suggestion is, I forgive you. You are entitled to hate. Try to overcome your negative feeling by thinking of the simplicity of the procedure and the advantage for the patients based upon the mounting evidence. And if still not an ectopic pregnancy. And be courageous, call Timor at any daytime or wake him up at night, sharing your true feelings about him and his balloons. So basically, here are all these excuses. All of these seem to be surmountable, and I think that you can do that. Now, here is my treatment procedure. If there is a heartbeat, then I'll go on the other side in a second. If it's negative, recheck at 3 days. If no fetal heart, after 3 scans, or 7 weeks by reliable dating, you follow up by ultrasound, by HCG until it's 0. Now, if there is heartbeat, counsel based on evidence. If the patient requests the TOP, select an appropriate treatment to stop the heart activity without delay. Start immediately. And I start with intramuscular methotrexate. Determine the gestational age. Before 8 weeks, double balloons or local injections. Past 8 weeks, local injection, question mark embolization, and really past very much over 8 weeks and no fertility, desired gravity hysterectomy. In the 2 first cases, as needed weekly HCG and ultrasound, watch for possible enhanced myometrial vascularity, beautifully shown by Davor. If the patient is interested in continuing the pregnancy, counsel for possible placenta accreta spectrum. Determine if placenta in the gestational sac is on the scar or in the niche. Measure the myometrial thickness and see whether it's bulging into the bladder or not. Use the article that Andrea wrote, and that will talk about the thickness of the myometrial layer. If it's less than 4 millimeter, it is high risk for increta, percreta, and cesarean hysterectomy. If it is on the scar, not on in the niche, or type 1, or it's more than 5 millimeter, it's low risk for PAS and cesarean hysterectomy. So, summary of my lecture. CSP is a dangerous, life-threatening baby placenta accreta. 2, no uniform diagnosis and treatment protocols are available. If termination of the pregnancy with a positive heartbeat patient is desired, do it without delay. The dual action of the cesarean right planning balloon is effective and simple to use. It can also treat cervical pregnancies. Its use could be or should be, I don't know, integrated into a comprehensive treatment algorithm as one of the possibilities. What we do, and we also discussed whether I think that Amar discussed this, whether we should screen for it. And I have a lot of comments on those 3-4 slides, but we give our patients who are discharged from the hospital after a cesarean delivery this little brochure that asks them to please come and get scanned if they get pregnant after a cesarean delivery. I think that is logical. And yes, we have to determine its usefulness. There are 2 articles now talking about it, one by our Italian group and another one by the Nicolaides group. And again, international registry was created. We encourage to upload these cases. And as I always say, just do it. Thank you very much for your attention. And if your language is not up here, email me and I'll put it on. Thank you.
Thank you, Ilan. Thank you so much for a fantastic presentation.